The new BG Dental case is dedicated to a variety of porcelain partial restorations for posterior teeth like veneers, veneer-lays, and veneer overlays. So keep in touch, let's watch it, and let's go. Hello dear friends, we are back with a new episode of the BG Dental Cases. This time I prepared for you a very interesting presentation that is dedicated to aesthetic and functional restorations. As you can see from the initial slide here, we have a tooth wear, so we have to do a lot of work. Actually, it is full mouth rehabilitation, but today I will focus mainly on posterior region for posterior teeth, explaining different types of partial bonded restoration rehabilitating posterior teeth. Because last case that we actually presented you recently was also touching partial restoration for posterior teeth, and we got a lot of questions and requests to show you a little bit more from clinical perspective different types of restorations, especially when people started to download our PDF file, which is Atlas of Posterior Preparations. And today actually you will see some different types of restorations for posterior teeth that may be helpful for your daily basis. So let's continue. We have initial situation from occlusal view, upper and lower jaw. Multiple teeth are worn. We can have also caries defects, all restorations, some cracks, some crown that have to be replaced for the new restorations. Actually, this case we designed, we planned as a full mouth rehabilitation in new position, in the CR position, or in TRP position, if you would like to say. Again, it's very deep topic regarding full mouth rehabilitation, especially treatment planning. I think that maybe in the future we will touch a little bit more deeper into that one. But today I will be showing you restorative component, restorative part. Okay, by the way, if you are watching us for the first time, I would like to say that we have plenty of such cases, step-by-step cases that are actually like a small webinar or mini webinars. If you want to know more, you can just see the link below this video in description, and there are many, like more than 20 episodes of BG Dental cases. So, okay, this is initial case. You can see, by the way, the date is the October 3rd, 2014. Pretty old case, but anyways, pretty interesting and well documented. Here we have adhesive Mocap, and this Mocap helps us to check if our occlusion planning was correct. So we can put these 28 units Mocap into the patient's mouth. There are many different types and strategies to transfer that kind of Mocaps into the patient's mouth, so adhesive Mocaps, injectable Mocaps, printed or mill Mocaps, etc. So we can check our position, we can check the bite of our patient. In this case, we raised vertical dimension of occlusion. So definitely we would like to understand if the jaw position is correct and the bite is correct. After that, we can go straight to the restorative part, which is preparation, and we will do our preps through the Mocap, because Mocap actually gives us understanding about the final restorations, and also it helps us to be conservative during process of reduction. We have to follow guidelines and instructions for the material that we are going to use by manufacturer in such cases when we do partial adhesive restorations for posterior teeth. The material of choice in our clinic is Emax, or lithium disilicate. It can be pressed or it can be milled. And as far as we know, the minimum thickness of Emax, monolithic Emax, for overlay preparations or tabletop preparations should be about 1 millimeter. So we take our depth cutting burr, which is 1 millimeter. We make these grooves in the Mocap. We take a pencil or marker, we mark these grooves, and together Mocap and tooth structure will give us this 1 millimeter. Okay, so afterwards we can remove the Mocap and we exactly see how far we went into the teeth of our patient. In this case, you can see we are pretty conservative because we have possibility to add posterior teeth in such a case. The next step will be to merge these grooves and also to prep considering initial clinical conditions that we have in that particular case, like caries defects, some cracks, old fillings, secondary caries, aesthetic needs from the patient side, and so on and so on. So here you can see the step 1 preparation that was over. Last or second molar is very interesting. Second molar, you can see we prepped without breaking into proximal contact. We just prepped occlusal surface. There was a small caries defect from the mesial side, so we have to extend our preparation to the mesial side. But anyways, that type of preparation can be named as tabletop. Actually, it is tabletop. It's like a cover on your table, okay? And it is not retentive. It is completely adhesive restoration that has to be bonded. So that is tabletop. Why tabletop in this case? Because the second molar is not visible in smile line. When patient is smiling, when patient is laughing, when patient is screaming, you cannot see vestibular and lingual sides, so we can be really conservative for our restorative components. First molar, considering the fact that the walls were pretty thin after old restoration removal and caries removal, we had to cover cusps just to reinforce them, but also in such a case we redesign occlusion. That's why we need to cover the whole occlusal surface for full mouth rehabilitation case. Lower 5, it is same as lower 7. Basically, it is tabletop. Why tabletop? Because of the occlusal rehabilitation and also extension to the vestibular part because of the aesthetics. In this case, we are changing patient's color of the patient's teeth, so we have to go with vestibular preparation. Same for lower first molar. By the way, I didn't mention that. If we will do, for example, aesthetic rehabilitation, aesthetic case with no functional rehabilitation, and we are changing patient's color in like 3-4 shades, we will have to do the pretty similar preparation on lower second premolar, because lower second premolar, the cusps of lower second premolar, vestibular and lingual, are pretty equal, okay? And when patient opens mouth, you can see occlusal surface. So in most of the cases, because of aesthetics, we have to go for the occlusal coverage of the second lower premolar. On upper jaw, it is different approach. On upper jaw, you can go for window preparation. On upper jaw, you can go with a partial cusp reduction preparation. Lower first premolar, this one. We had to cover that cusp because it is prominent, it is high, the vestibular cusp is pretty high. So again, for the aesthetic cases, we do the same preparation, but in this case, we are doing our functional rehabilitation. You know that the vestibular cusp is stamp cusp, so actually functional cusp. So we have to involve the cusp into the functional envelope and the functional rehabilitation. If you want to know more about this, again, and you didn't download the atlas of posterior veneers, it is PDF file actually. Each type of preparation is we took picture from different directions, from occlusal view, from vestibular aspect, from the sagittal view, so you'll get ideas how a window preparation looks like, how a partial reduction looks like, a single cusp reduction, a whole occlusal surface coverage, etc. So this is like a free of charge, like a gift for you. You can download this PDF atlas following link below this video in description. Okay, but if you want to know more and to see how actually we prep every single type of these restorations, we prepared online masterclass that is called Posterior Veneers. It will be live, so you will be able to see step-by-step guidelines and guides of preparation for veneers of posterior teeth. The link to the online masterclass you can see also below the video that you are watching right now. This video is about benefits that you will have from our online workshop. Presence effect. This is a unique feature by Belograd Academy that literally moves you to our training center and you can stay close to speaker. This is like over-shoulder format. The training process is filmed through the video system from the microscope, and there are two more cameras broadcasting close-up and general view. This way, you can see everything in precise details. Efficiency. Do you agree, guys, that over-shoulder workshop with detailed video and explanation is way better than regular slides? The third benefit is convenience. So basically, you don't need to go anywhere, and you can study in comfort conditions, in your home, in your office, during running exercises, from your phone, from your computer, from your tablet, and you can do anything you want with the content. So join us as we shifted online education into the next level. Okay, so next, you see here macro picture when caries was removed, small crack lines that are in enamel and partially indenting. These cracks are not stained, they are not deep, so actually you can seal them with adhesive materials and nothing will go wrong. Actually, this is the step of adhesive sealing. So basically it is immediate denting sealing. All denting was sealed with composite and bonding agent. Also, we covered undercuts with composite resin to modify our designs to be more conservative and easygoing for dental technician to perform nice fit of the restorations. Then we removed oxygen inhibited layers. There are many ways to remove oxygen inhibited layers. Actually, you can use glycerin gel and light cure through the glycerin gel, or you can take ethanol and wipe everything with ethanol. It is important to do, by the way, because when you will take impressions with PVS material or with a polyether, some polyethers will not polymerize in presence with oxygen inhibited layer. And also it is important before you do your provisional restorations. So next appointment, we fabricated monolithic Emax restorations, veneers, actually they are veneer-lays, veneer overlays and veneer onlays that we're going to bond, rubberdam isolation again. In the Maori protocol, when we do this IDS and cavity design optimization with composite resin, we use sandblaster, aluminum oxide 23-27 microns or 50 microns just to sandblast everything. So the surface will be well prepared for bonding, and then we go for a regular bonding process, regular bonding protocol. Enamel should be etched 30 seconds with phosphoric acid. If you still have some dentin exposed, then you etch it. If you use total etch adhesive system, if you're not using total etch adhesive system, you are using self-etch, so in this case you skip dentin etching, then you dry everything, you rinse everything, you dry everything, you apply adhesive according to instruction, and then you use your resin cement to bond your indirect restorations. In this case, we bonded them with a light curable material, highly filled flowable composite. Actually, I used for cementation, just to remind you again, before, after. And then she promised, by the way, to remove this wisdom teeth. Actually, we need to remove this wisdom teeth because there was interference. And here we have a part of actually image from 2021. So we started 2014. Here we have a 7 years recall, 2021. Pretty good and stable result. The only thing that I'm not very happy with is the length of lower incisors. The reason why I made them too long, because I tried to be very conservative with upper teeth, and we ended up with veneers without involvement of palatal side. Nowadays I would play a little bit more clever with occlusal plane, and I will include palatal side of upper frontal teeth into the dynamic function in that particular case. But anyways, 7 years later, patient is happy, all is stable, all teeth are in place. Me as a dentist also is happy. 7 years, it's a good result for big case, including tooth wear and multiple restorations. Okay, so one more time, would like to remind you that we have our online masterclass about posterior veneers. If you're interested in, please follow the link in the description to this video. If you want to upgrade your practical skills, I will be more than happy to see you here in Kiev, Ukraine, in our training center for hands-on courses. We have plenty of hands-on courses about preparations, veneers, composite restorations, endodontic treatments, functional rehabilitations, and so on and so on. So again, I will be more than happy to see you in person, but not just in virtual life. I would like to wish you to be healthy, and may the dental force be with you. Bye bye, guys.